Okay. Good afternoon, everyone. Welcome to all of you for this 95th CME Talk series and the first CME event in the year 2023. Today, we have two speakers for this 95th CME Talk, Dr. Sudha Arumugam and Dr. Uday Kumar Marimuthu. Let me introduce to the first speaker of the day, Dr. Sudha Arumugam. Dr. Sudha Arumugam earned her MBBS in 2008 from Stanley Medical College, Chennai, India, and her MD Pathology in 2013 from the prestigious Jipmer Institute, Pondicherry, India. Dr. Sudha's areas of research include medical education and prostate pathology. She was awarded an internal grant to study Nectin-4 expression in non-urothelial malignancies, and research has been published in international journals. Dr. Sudha has over 10 years of pathology teaching and research experience. And Dr. Sudha Arumugam is currently a senior lecturer in the Unit of Pathology at the Faculty of Medicine, Bioscience, and Nursing. She is also the Year 2 coordinator for the MBBS program at the Faculty of Medicine, Bioscience, and Nursing. And without any further ado, I would like to invite our first speaker of the day, Dr. Sudha Arumugam, to talk on recent developments in the diagnosis of prostate tumors. The floor is yours, Dr. Sudha.
Okay, thank you, Dr. Suresh, for the wonderful introduction. So here I am in front of you with the topic of recent updates in the diagnosis of prostate cancer. So as the audience here, I hope is not like fully the pathology group. So it's going to be a mixed group of clinical and non-clinical and non-medicos also. So I will try to keep this more simpler, which everybody can relate to. Right. So the contents of the today's presentation will be in this flow. So I'll be talking about the guidelines for the screening, the techniques which we use, when and how to do the biopsy, what are the techniques to improve the biopsies, and very briefly about how the histopathologist diagnose the prostate cancer, grading, staging, and finally the prognosis. So this will be the flow of my talk today. So first, starting with like what is prostate cancer, or not exactly what is the significance, like why should we know about this? So as you can see here in this slide, prostate carcinoma is the most common solid internal malignancy in men, and it is one of the most common extracutaneous cancer. So almost every 2.4 minutes, a new case of prostate cancer is diagnosed in the US. So there are many risk factors, like a male above age 50 years is at risk of developing prostate cancer. And there are certain factors which can increase or accelerate and make and give rise to an early risk of prostate cancer when persons have a family history, or when they are of African American descent, when they have exposure to certain toxic chemicals or certain diets. So all this can increase the risk of prostate cancer. So generally above 50 years, and as the age increases, the risk of prostate cancer also increases. So going to the genetic traits which can be associated with the prostate cancer. So there are a lot of genetic mutations which are associated with increased risk, right? So we have the BRCA2 mutations, the Lynch syndrome, and you can see the full list here. So the significance of this is these men with such genetic mutations are at earlier risk of development. So they can develop prostate cancer even before the age of 40 or 45. So they need earlier screening starting from 40 years of age, or even earlier if there is multiple family members who have been affected. And such tumors are associated with a higher grade of prostatic carcinoma, nodal involvement, and metastasis also. All right, so This requires an early detection. So how do we detect, or how do we screen? So screening of prostate cancer is done in persons who are asymptomatic, right? And for that, we cannot just do screening in any persons. Before that, you will have to do a counseling on them and explain to them the risks and benefits of the testing, right? And the risk of developing a prostate cancer. So we will be using the term a well-informed man for those who have undergone this type of counseling, right? So the screening technique or the screening test which we'll be using is mainly the PSA, the prostate specific antigen levels. So what should we do? So offer an early PSA testing to those who have undergone the counseling and who are at risk of developing the prostate cancer, right? So men from 50 years of age, it's a general risk, and if there is a high risk, such as a family history or African descent or those carrying all the inherited mutations, so in them we start earlier, right, by 40 to 45. So, what is considered as suspicious or needs further checking? So, a PSA level of more than 2 nanogram per ml at 60 years of age, right? So, this might need further follow up. Or if a person has less than more than 1 nanogram per ml at around 40 years of age, will require follow up at every 2-year interval. But if the PSA level is above 2, right, like very like quite elevated in the range of 3 to 10 or even higher, then we straight away go for further investigations to confirm, to have a confirmative diagnosis. And another important thing which we have to consider when we're screening for prostate cancer is the life expectancy of the individuals. So, if a person has a life expectancy of maybe less than 10 to 15 years, so there is not much benefit of diagnosing and treating, because treating the patient and all the treatment strategies have a lot of side effects, right? So in men who have a life expectancy of less than 10 years, so it doesn't have much benefit. So very well we can avoid screening also. So this is as per the recent guidelines published by the European conference, right? Which was the Urological Society, the International Society of Urological Pathologists, and all the urological scientists together in the conference held at Amsterdam in 2022. So most of the guidelines which I'm or the discussion topics will be from the updated guidelines listed here. Okay, so how do we clinically diagnose? So one is we screen if we find an elevated PSA, so we can do the further test. Or if a person is symptomatic, so what would be the symptoms of prostate cancer? So they can have abnormalities in the urinary flow. They can have increased frequency of urination or urgency, or many other symptoms which can relate to blood in urine, frequent urination, and and so on, hesitancy of urination, and so on. Other warning signs which could suggest a metastatic disease can be bone pain, right, or weakness or numbness in the legs, and other symptoms when the nerves are affected. When there's a nerve infiltration, the patients can have sexual dysfunction also, right? So this would be the signs and symptoms of prostate cancer. And if any patient has any of these symptoms or all of them, then we should further investigate for prostate cancer. So what do we do usually? So we can do, based on that, the clinical examination in the form of digital rectal examination, right? So DRE. DRE is done, and the PSA levels are also checked. And so PSA is one of the important test which is like an early screening test for prostate carcinoma. Then the definitive diagnosis will depend on the biopsy and the histopathology findings, right? So now going to the DRE. So digital rectal examination is not a very comfortable procedure for men, and I think most of the men will pray that they don't have to undergo this procedure, right? But it is for examination of prostate, because it's not, it's an internal organ, it cannot be palpated. So this is one of the examination techniques which allows us to palpate the prostate. And if there is an abnormal finding in the DRE in the form of hard and nodular prostate, so prostate carcinoma, there's a very high suspicion of prostate carcinoma. And as studies have shown that more in almost 18% of cases, just by DRE, prostate carcinoma can be detected. Right. So if there is an abnormal DRE, then we proceed with doing an MRI and biopsy. So it is a very strong predictor of advanced prostate carcinoma. Not just making a diagnosis of prostate carcinoma, but a presence of abnormal finding in the form of hard nodularity in the prostate can indicate that the person has an advanced prostate carcinoma. Right? So that is the significance of DRE, which we should keep in mind. So then going to PSA. So for most of our screening tests, we do the PSA, right? So what we have to remember here is PSA is organ specific, but not cancer specific. So it can be elevated in other conditions like the BPH, prostatitis, or atrophy of the prostate. So all these conditions can also show elevation of PSA. So then how do we use it? So just one time elevation of PSA is not suggestive of prostate cancer. So it is a continuous parameter, and continuously elevating levels or a repeat PSA showing a higher level is an indicator of prostate carcinoma. So that being said, so the other aspect of PSA is like when PSA was like a wonder test for the screening of prostate carcinoma. And there were so many of these which were done, and it resulted in an increased rate of diagnosis of prostate carcinoma, and there were increased number of biopsies being performed, which resulted in diagnosis of early cancer, which was good. But as the studies show and as the years pass, we have learned that most of the early cancers might not actually require any treatment, right? Because the prognosis is very excellent, and they take like with around 10 to 15 years, the carcinoma has a very indolent course and doesn't cause any problem in the patient. But rather than that, the treatment which is being offered can cause a lot of side effects, and it can cause the morbidity in the patients. So, increased use of PSA resulted in overdiagnosis of early cancer, or in other words, clinically unimportant disease. So now our goal is to decrease the incidence of, or to decrease the diagnosis of clinically insignificant or unimportant disease. So what do we have now? So we have a lot of other biomarkers and other tests which can help us, which can help in reducing the unwanted biopsies which are being done. Right. So so the next part of the discussion will be dealing with the recent biomarkers which have been developed and which help in predicting the risk of carcinoma. Right. So by doing that, it increases the specificity of PSA. It predicts the risk of prostate carcinoma, right? That the presence of carcinoma cells, and whether this tumor will progress aggressively, or it is going to be a very low grade and a silent tumor. So it can help in distinguishing the various grades of the tumor also. And obviously reduces the cases of overdiagnosis. Right? So there are different markers. So we have the pre-diagnostic markers, which indicate that yes, if this is elevated, the person may have or has a higher chance of having a prostate cancer, right? And if a biopsy is negative, right, we didn't find what we expected, then should we do a rebiopsy in the patient, or should we just wait for a few years and then do a biopsy? So all for all that, we can get the answers from doing these biomarkers, and also for deciding the treatment plan and the prognosis. These biomarkers are helpful. And there are different biomarkers for each of these categories, which we will be discussing. Right? So one of the well approved and like well studied and an FDA approved index or an indicator is the PHI, right? The Prostate Health Index. So this is a formula based on several PSA forms. So it takes into account the total PSA, free PSA, and the 2 Pro PSA also. So when we use this, it increases the specificity of prostate cancer, diagnosis of prostate cancer, and a higher PHI value correlates with the higher grade tumor, right? Higher Gleason score. So what is Gleason score? I'll be talking about in the next few slides. Right? So Gleason score indicates the behavior of the tumor cells, right? So if the PHI value is very high, then it would indicate that the tumor is highly aggressive also. So usually the cutoff of PHI, which is an indicator of prostate carcinoma, is in the range of like 30, right? So above 30 can indicate prostate carcinoma, and we should do a biopsy in those patients. Suppose PHI is less, right? Maybe just 10 or 15, then we might not need to do a biopsy immediately. Maybe we can just follow up the patient with every 2 years, and we can just watch and see, right? The patient might not need an active biopsy immediately if the PHI is low. So similar to PHI, we have other scores or other tests like the 4 Calicrant panel or the 4K score, right? So this, in addition to the PSA, it also uses the human Calicrant too. So similar, the utility is similar to PHI, but this is still not FDA approved, right? So, and not followed, not done in most of the institutes. So it is still in the research phase. So if approved, it has almost similar specificity to PHI. Okay, so it can also improve the prediction of high-grade prostate carcinoma and diagnose clinically significant prostate carcinoma. So in another few years, so after a person has high PSA level or raising PSA level, we might have to do these indicators to see if the patient will require a biopsy or not. If the values are very low, then we can hold on to the biopsy. If the value is high, then we proceed with the biopsy and go for the further test. So other tests which have similar application is the Select MDX, which uses the mRNA biomarkers, right? So mRNA biomarkers like OXC6 and DLX1. So this also has similar utility. So other tissue-based markers. So some are blood-based, some can be found in the urine, and some are tissue. So if you see, there are other biomarkers which I have listed here. So confirm MDX, which is a tissue biomarker, and this assesses the methylation abnormalities in the surrounding tissue of the tumor. Right. So any development of carcinoma in a particular organ will cause methylation abnormalities in the adjacent tissue also. So we can detect the abnormalities in the adjacent tissue, which will confirm that the patient has a prostate carcinoma, or it predicts the risk of prostate carcinoma. And this can also be used to assess if the patient may need a repeat biopsy if the initial one was negative. Right, so all these which is listed here, the P10, Decipher, Polaris, these are mainly used to decide on whether to treat the patient now or just actively follow up the patient, which we call it as active surveillance. Right? So this is for treatment planning, and they all are based on not just one factor but different RNA biomarkers. So Decipher analyzes 22 RNA biomarkers, and Polaris with 46 RNA biomarkers and the Gleason score. So it takes into consideration both the histopathology as well as the RNA biomarkers in the tissue. Right? So these are all the biomarkers. Not all are in use. Right? So most of them are still in the research phase and still not completely approved. Okay, so just to sum up what we have discussed, so we have the blood-based markers. So one of the PHI is like being used in many places, and then the 4K score. So the utility of this is it can predict the risk of clinically significant prostate carcinoma in men if they have a PSA level of more than 3 nanograms, right? And then the urine-based biomarkers, which are the PCA3, prostate cancer antigen 3, select MDX, the Michigan prostate score, XODX. So all these are used to assess if a repeat biopsy is needed in an initial negative biopsy. And most of these urine-based markers are measured following a DRE examination. So when a DRE is done, there can be, there is some manipulation of the prostate tissue, which can result in the release of these factors in the urine, right? And they are measured. Okay, so when should we do a prostate biopsy? So a person with high PSA level, so do we do a prostate biopsy in all of them? No, right? So we should first do one of these, right? So the best would be the PHI, and in the future, maybe we'll be using the other indicators also as shown. If the PHI value is very high, then we go on with the biopsy. If the biopsy is positive, then you look at the grade and you see the staging and you plan on the treatment. If the biopsy is negative, all right, so then does it mean that the patient does not have cancer? Right? Maybe he might not have cancer. It may be just any of the other like non-neoplastic conditions, but it could be cancer also. So we do a follow-up PSA and the other test, right, after a few months to see if the patient needs a rebiopsy. So if any of these are abnormal or elevated, then we can do a rebiopsy in those patients. So this is based on the screening and whether to do a biopsy or not. So how can we improve the biopsy technique? So this is, we saw how, when to do the biopsy, right? But how to get the best out of the biopsy which is being done. Okay, so the technique of biopsy is also very crucial in getting the proper material for the from the cancer tissue. So there are various techniques which are available. So like very well used is the transrectal ultrasound guided biopsy or the TRUS guided biopsy, right? So this is what we do in the TRUS guided biopsy. So through the transrectal route, both the ultrasound probe and the needle, right? The the biopsy needle go through the transrectal route and you take the biopsy from the prostate. So the probe will guide you the place from where the biopsy is being taken. Okay. So the more recent advance is using a transperineal approach for the guided biopsy. So in transperineal approach, what do we do? So the probe, the ultrasound probe is in the rectum, right? But the biopsy needle goes through the skin between the anus and the scrotal skin. Right. So here is the biopsy needle, and it goes to the prostate and takes the biopsy. So this reduces the infectious complications which can develop following a following which were uh, which were developing following a transrectal approach, right? So the reason norm is to do a transperineal ultrasound guided biopsy, all right? And the more advanced versions would be using a Doppler blood flow enhanced ultrasound, all right? So this will tell you, because the tumor cells usually have an increased blood supply, and the Doppler will tell you the areas which has the increased blood supply, so that you can target those areas to get the appropriate sample from the prostate. And the more advanced and the best would be the MRI transfusion guided biopsy. So this uses the MRI along with the transrectal ultrasound. So both the computers will fuse both the images, and with the help of the ultrasound guidance, we will be able to target the appropriate areas. So MRI is much better than TRUS in identifying the abnormal cancer areas, right? So MRI guided biopsy is the way to go in the future. Okay, so now how many biopsy course should we take? So usually in prostate, it is just the needle biopsies which are done. So we have the systematic biopsy versus targeted biopsy. So initially, like in a few years ago, it was only the sextant biopsy, maybe just taking a few cores from the right lobe, from the left lobe, and six cores, right? And then just analyzing them for the histopathology. So systematic one, again, you have like 6 cores from each of the lobes, but the recent technique is to do a targeted biopsy also, or the best would be to do a systematic and a targeted biopsy. So in the targeted biopsy, you just take the biopsy from the abnormal area highlighted by the MRI, right? So that would be the targeted biopsy as it's being done here. Systematic is taking biopsies or core needle biopsies from all the different lobes and segments of the prostate. The best approach would be to do a systematic plus targeted biopsy. Okay, sorry. Okay, so why should we have so many cores, right? Why not just do the targeted biopsy? So if you look at the picture here, you can see that, okay, so this is the biopsy needle, right? And the abnormal area or the tumor area is here. So the needle has completely missed the cancer area. Or there could be an abnormal area, but it is not a significant cancer, maybe just a very low grade cancer as shown in this second picture. Again here, the highly advanced cancer has been missed. Same here, the needle has passed through it, but it has overshooted and it has gone beyond the cancer area. So in all these cases, the cancer has been missed, right? The aggressive cancer has been missed. So to avoid all this, it is better we do more course and we do a systematic and targeted biopsy. So the recent recommendations for doing a prostate biopsy are at least 8 systemic biopsies are recommended in prostate if the size of the prostate is 30 cc. And if it is larger, then we can take around 10 to 12 core biopsies. And the route is transperineal, right? So transperineal route is preferred rather than the transrectal biopsy. And wherever possible, always to do an MRI before taking a biopsy. If possible, and MRI transfusion biopsy would be the best. Okay, so after we take the biopsy, so it goes to the pathologist, right? So when you send the samples, so each of the core, so Suppose we take 12 cores from the prostate. So each of the 12 cores should be labeled separately and sent, right? So that then only we'll know which part of the prostate gland is affected so that you can further plan. So how do we diagnose? We diagnose based on the histological features. So there are major features which includes the architecture. We look at how the glands are arranged, whether they're small, large, whether they have a complex pattern, is there any nuclear atypia, and is there are the basal layer of cells absent or not, right? So these would be the three main criteria based on which we diagnose prostate cancer. Minor features would be the additional features which would support the diagnosis of prostate cancer. And so this would help in diagnosing to see whether there is presence of prostate cancer cells or not. So if there is presence of cancer, so then what is the next step? So any cancer cell, cancer tissue present should be graded, right? So grading of prostate cancer has to be done, which is done by the Gleason grading system, which is based on the histological pattern of arrangement of the tumor cells, right? And as I told you, it reflects the differentiation or the behavior of the malignant cells. So the recent updates in the Gleason grading is there are some changes in the grade 3, grade 4, which I have mentioned here. So you can, the first picture which shows here is the earliest, the first Gleason grading system, right? And the second picture shows the most recent consensus on the Gleason grading. So 1 and 2, so we grade the tumor cells from 1 to 5, right? So this is how we grade. And if you see the Gleason score 3 group, there is some variation. So most of the cribriform, so cribriform are all these patterns, right? So cribriform and the glomerular pattern have all moved to grade 4 in the recent 2019 consensus. And in the grade 5 also, so all the comedocarcinoma, initially some comedocarcinoma was included in grade 4 also, but now all of them have been moved to grade 5. So any amount of comedonecrosis, if it is found, it takes it straight to score 5 or the Gleason pattern 5. Okay, so this is the grading, and based on the presence of tumor cells, usually it is a combination of two scores, right? If we suppose we see that there are 40% of tumor cells showing Gleason pattern 4, and there are 60% of tumor cells showing Gleason pattern 3, then we give the score as GS 3 plus 4, right? The one which is majority will be the primary pattern, and the minority will be the secondary pattern, and the summation of two will give you the final score, right? So that would be a Gleason score of 7. So now regarding this also, there are some changes, some updates which have been given, and there are certain conditions when we do not give the grading on the tumor cells, like when the tumor cell, when the person has been treated with androgen deprivation or chemotherapy or radiation, then it can affect the morphology of the tumor cells, and it can result to either a false higher grade or a lower grade. So we do not grade the tumor which has been subjected to these treatments. On the other hand, a person who has undergone alpha reductase inhibitor therapy or cryotherapy or ultrasound ablation, it doesn't affect the grading because the morphology is unchanged. All right. So these are some exemptions from the Gleason grading. So now the recent update is, instead of just giving a Gleason score, all right, so this is the Gleason score. Usually we mention it as Gleason score of 6, 3 plus 3, or 7, 3 plus 4, 7, 4 plus 3, right, 8, 9, 10. So this is how the Gleason score is written, given in the report. So this could be quite confusing for many clinicians or the surgeons. So to make it even simpler and to give a more clearer report to facilitate a better communication of the diagnosis and the behavior of the tumor to the clinicians, the grade grouping was adopted. So in grade grouping, so there are only 5 groups, right? So from grade group 1 to grade group 5. So grade group 1 is 3 plus 3, right? So less than or equal to 6. And any grade below 6 or score below 6 are now non-existent. So they are not considered at all. They are all insignificant cancer. So all the grade grouping starts from score equal to or above 6 only. So grade 1 has a very good prognosis or the best prognosis. Grade 2, it is low grade, right? It has a Gleason score of 7, and grade 3 also has Gleason score of 7. But the difference is in grade 3, grade group 3, the predominant pattern is 4. So there are more than 50% of tumor cells showing pattern 4. So it leads to a poorer prognosis when compared to the Gleason score 7 with predominant pattern being 3, right? And grade 4 and 5 have the prognosis becomes worse as we move higher up. So grade grouping was done to better communicate the nature of these tumors to the clinicians. And another aspect is the quantification of a high grade carcinoma. Suppose we take the grade group 3. So grade group 3 is a Gleason score of 7 with so we take the Gleason score of 3 plus 4, right? 3 plus 4, this would be actually grade group 2. Sorry, so this would be a grade group 2. So grade group 2, if we just mention the grade group 2, so any clinician may assume for the better prognosis that it has a predominant Gleason pattern of 3. So it could be also like 90% of Gleason score 3 plus only 10% of 4, right? Which has a very good prognosis. But suppose the actual tumor cells which were observed were Gleason score of 3 of only 60%, but 4 of 40%, then this changes the prognosis and the person has a bad prognosis compared to this group, right? Where the Gleason 3 is 90%. So the reason one is it's better to also mention the quantification of each of the patterns in the report, right? So an ideal pathology report from the histopathologist should contain the diagnosis of the tumor, right? Prostatic adenocarcinoma, Gleason score, what is the quantification, right? Gleason score 3 is how much percentage, 4 is how much, or 4 plus 5, what is the percentage, and then the grade grouping. So all of this should be mentioned in the report. And then moving on to the staging of prostate carcinoma. So there are various staging. So the staging which is followed for most of the tumors is the pathological TNM staging. Right. So this is the staging which is used, and we also have WHO staging, but mostly for histopathologists would be using the TNM staging, which takes into account the tumor size, the node lymph node status, and the presence or absence of metastasis. The other staging which are implicated in prostate carcinoma is the clinical staging, right? The clinical tumor staging, which depends on the DRE findings, right? And the most recent one is the staging based on PSMA PET CT finding. So PSMA is the prostate specific membrane antigen. So PET scan done with the PSMA antigen tagging is the recent staging system, and it is called as the molecular imaging staging. So MITNM staging. So these are some of the staging systems available for staging of prostate carcinoma, right? So, and the more advanced techniques would be like MRI, not just the plain MRI, but the multi-parametric MRI. So, what do we do in multi-parametric MRI? So, in this first, we do a standard MRI and then a second MRI, which is more advanced, like the diffusion weighted imaging or dynamic contrast enhanced MRI or MR spectroscopy is done. So this gives more detailed view of the the involvement of the prostate by the cancer cells and the extent of involvement, and it can also give idea on the aggressiveness of the cancer. The next is the enhanced MRI, where with the help of MRI, we can also find the positive lymph nodes, right? The lymph nodes which have the metastatic deposits. So the patient is injected with some magnetic particles and the scan is done the next day, and analysis of the pre-injection and the post-injection scan will give the information about the positive lymph nodes, right? So these are some of the advanced MRI techniques. And as I told you, the PSMA PET scan, it uses, instead of using radioactive traces, so that radioactive traces are attached to the PSMA antigen. And PSMA being prostate specific, so it can detect metastasis in different spots with a much higher sensitivity when compared to the other test. So even though it is like more accurate for staging than CT and bone scan, but till now there's no outcome data, right? No proper outcome data on this test, this newer modality, to further plan and manage. Okay, so maybe it may take another few years, so that when we have data on this to analyze and whether to go on with the further approaches with these techniques. And then once we have done the diagnosis, staging and all, the next question would be, how do we treat the patient, or do we treat them, or we just watch, follow up them, right? So here the terminology used would be the active surveillance. So whether we do an active surveillance on the patients or treat the patients. So for this, we go back to the grade group, right? So the low risk grade 1, uh, the grade 1 tumors are considered as low risk or the low grade tumors. So they can be very well done, categorized as active surveillance group. And if the clinical stage is just T1C or T2A and PSA level is less than 10, they can be just actively watched or followed up. So what do we do in them? We do a repeat biopsy every 3 years for 10 years and look for any abnormal findings. If there is an increase in the PSA level or the MRI, or there are any abnormal DRE findings, then we do a biopsy in the patient. We do a repeat biopsy. And if the patient needs treatment, right, then we do offer a low dose brachytherapy, mainly the radiotherapy in these patients, right? And the intermediate risk group, again, we have to decide whether they need active surveillance or they need treatment. So for that, if the patient belongs to grade group 2, if the pattern 4 is less than 10%, the PSA level is low and the clinical staging is less. And on MRI, if the tumor volume and the extent of the tumor is less, then we can go on for active surveillance. If not, if the parameters are not met, if the pattern 4 is higher, right, and if there is a higher tumor volume, higher disease extent, then we may have to go in for actively treating the patient. And to decide on whether we should do an active surveillance or treatment, there can be some markers which can help, as we discussed earlier. So the PROMARK, Decipher, Prolaris, and Oncotype, right? So all these can help in assessing the risk and aggressiveness of the prostate cancer. So finally, just to sum up, what we have discussed so far. So this is the approach. All right. So any patient with a PSA level about 2 nanogram per ml needs further investigation. Right. So one is we do a DRE. It's just an examination technique. So you do a DRE. If you find an abnormal DRE, or if the DRE is normal also, in any case, when the PSA is high, we would further go in with the further tests like the PHI, 4K score, and MRI. Right. And we also do a repeat PSA because we just don't take one time measurement of PSA. It has to be raising levels of PSA in subsequent test. So repeat PSA. If elevated, then you do this MRI, PHI, and 4K score. If repeat PSA is normal or if it is low, then just follow up the patient maybe every 2 years or every 4 years, depending on his risk status, depending on his other risk factors. And suppose if MRI and all following DRE, MRI, everything is normal, just follow up again as per the status. But if the MRI is abnormal, shows suspicious areas, the PHI is elevated, then we do a biopsy. On biopsy, then we look at the tumor cells, the grading of the tumor. A low grade tumor, active surveillance. If it is an intermediate grade tumor, usually the 3, right? And the grade 2 sometimes can fall under the active surveillance, or it can go in for active treatment also, depending on the pattern which is predominant, and so on, the tumor volume and so on. All right, so we will further check on the tumor quantification and the prognostic predictors, the ProMark and all those, to decide whether we do an active surveillance or treatment. And for high grade, high risk, which is the grade 4, 5, usually it will be the treatment with radiotherapy or radical prostatectomy. And suppose if the patient is too old with other comorbidities and the life expectancy of the patient is less than 10 years, and if it is an advanced stage of prostate carcinoma with a higher stage, then we can do a watchful waiting where we give a symptomatic treatment and alleviate the symptoms of the patients, like more like a palliative treatment. And if the biopsy is negative after all this, then we do a follow-up PSA. All right, follow-up PSA. Usually after 4 weeks has a better outcome, but it can be delayed also. And the analysis of PCA3, select MDX in the urine. If they are abnormal, we do an MRI and then do a repeat biopsy if needed. If it is normal, then we just go to the follow-up stage. And so this is the overall summary and the highlight of what we discussed today. And yeah. Okay, so with this, I'd like to end my presentation. So these are my references. Thank you.
Thank you so much, Dr. Sudha, for excellent coverage of the recent advancements in the diagnostics of the prostate tumors. And now I would like to invite the participants. You may ask any questions if you have to Dr. Sudha. You may post your questions in the comment section. Please post your questions if you have any in the comments section.
I think they don't have any questions.
Let us give it a minute. So we will wait.
I hope the topic was not very boring for everyone.
No, it
I
was
hope
very
you were able to
insightful,
follow
I think.
and relate to what I was discussing with you. So, final take-home message is any male above the age of 50 years, if you have not got screening for prostate cancer, better to do it, get it done once, right? And then based on your risk assessment, maybe you can decide when to have your next follow. But at least to have uh, one assessment, right? The PSA or the DRE should be done at least once.
I think there is no any questions, Dr. Sudha. Thank you so much once again for your excellent coverage of the recent diagnostic developments. Uh, Now I would like to invite Associate Professor Dr. Udaya Kumaran for the second talk of the today's session. And let me introduce Associate Professor Dr. Udaya Kumaran Marimuthu. He received MBBS, MD in medicine, and then after that MRCP from London University, UK. Associate Professor Uday Kumar has 35 years of experience working in health industry, hospitals, including 30 years of experience in the internal medicine at various government hospitals. For 7 years, Associate Professor Uday Kumar was the head of the emergency department at the hospital Tuamku Doppler, as well as a physician and the head of a geriatric unit at his hospital Tuamku, Jaffer, and PD Hospital. Professor Uday Kumar is a pioneer in the disaster management at Hospital Tuamku, Jaffer, which was incorporated in the Ministry of Health Hospitals in the country as the head of the emergency department. Dr. Uday Kumar Marimuthu is an associate professor in the Unit of Medicine at the Faculty of Medicine, Bioscience and Nursing, Masai University. So with this, any further ado, let me introduce our next speaker, Associate Professor Uday Kumar Marimuthu, to give a talk on uh, the stroke intervention. So thank you.
Yeah.
The floor is yours, Prof.
Yeah. All right. So we are going to talk on a topic which is of importance to us, and this actually entails all of us are at risk, at the moment, in the sense that most of us are above 50 already, and so we need to look at the secondary stroke prevention, focus on antithrombotic therapy, because this is a very big topic. Actually, the topic on stroke itself is a very big topic. So let's go on and discuss this topic with some evidence-based medicine there to support our management. So now, in the emergency department, it is not always that relaxing, because when you have got a case of stroke, and there are many stroke-ready hospitals nowadays in our country, and I can believe me that it's going to be, it's just like, in MI, well, here also time is the neurons. So you have to be on your toe. Ideally, it should be available 24 hours a day for the management. Now, why is this important? Why the change? Because over the years, we have noted that the new approaches have come in, thrombolysis has come in, thrombectomy has come in, instead of what used to be practiced at one time, after strokes, go on aspirin, right? It has been seen that overall prognosis has been improved. We can see here, thrombectomy, 1 in 3 will benefit. Thrombolysis, if it's done within 4.5 hours. In fact, it has been extended up to 6 hours. 1 in 7 of them will benefit, as compared to MI, which is 1 in 30. Now, the outlines of what my talk will be, because it's a very wide topic. What do you mean by the new definition of stroke and the risk factors? Which antiplatelet would you take, duration and the type? And what about post-stroke anticoagulant initiation? Which drug would you want to use? And when are you going to start this? Now, how serious is this problem in our country? We realized that the principal cause of death in 2018, we have seen that cerebrovascular disease itself is the third common cause of death, mortality in Malaysia. And in 2014, ischemic stroke was actually 96.2 in 1,000 population. That was actually the prevalence at that time. And every 40 seconds, one stroke case is actually reported all over the world, right? And every 4 minutes, we have one case of death due to stroke. And why are we talking about secondary recurrent strokes? Because 23% of ischemic stroke tend to have a recurrent, for which we have got evidence of drugs which are proven to be of benefit. Now, where are we today? You can see here a list of hospitals. You can see Sungai Buloh there, Hospital Kuala Lumpur there. These are all the statistics from the Ministry of Health, right? And the hospital which has been highlighted, Hospital Seraban Tuanku Jaafar, where I worked before. And when I was there at that time, when I left, we didn't have this program. However, from 2019, it has been introduced. And you can see that in 2020 itself, right? Up to 2020, up to June, we had 9. But in the year 2022, actually, right, 33 stroke activation was done in the emergency department, of which 12 were thrombolized with successful results. Now, what is a stroke? What is stroke now? There's a new definition for stroke. It has been seen that we also have to consider neurological dysfunction, focal dysfunction caused by cerebral, spinal cord, and retinal infarct. Okay, this is the new definition, which is proven actually by doing neuroimaging, and we have got very sensitive method of proving this nowadays. The old definition of TIA still holds, where we have neurological dysfunction for less than 24 hours, and it's also known as mini stroke. And remember the older terms, many years back, we always talk of the word CVA, isn't it? Cerebrovascular accident. Now, this is to be avoided completely because it has been seen that stroke is not actually an accident. It is preventable. So the consensus of experts from America feel that the new definition of stroke is to be used because it helps in the research purposes and also the management. Now, the classification of stroke still holds the Oxfordshire community, and we all know that we go by the anatomical distribution clinically, the old definition of total anterior circulation syndrome, partial anterior circulation syndrome, posterior circulation syndrome, all these are still relevant. And of course, there will be clinical features depending on the anatomical distribution and the extent of the stroke, which will also decide on the management. Endovascular basis, in case if thrombolysis fails, are we going to go in for thrombectomy? And anybody who come to the emergency department with suspicion of stroke or stroke mimics, there are a lot of stroke mimics are there, many. They will undergo a non-contrast CT scan first, right? And we need to have people who are well trained to interpret this if you are going to go in for thrombolysis early. Now, that is one. This earlier one was clinical classification. Now we have got another classification based on the etiology. And there was a trial, they call it TOAST trial. And they realized that ischemic stroke can also be due to cardiomyolism. And a significant number of them for which etiology was not known, cryptogenic, right? They call it ESUS, embolic stroke of undetermined etiology. And almost half of them actually didn't have embolic origin, right? They had thrombus forming in the large vessels, small vessel, and many of them, the cause has not been determined. So another thing is, another classification is actually based on the etiology, right? So that will help us decide on the treatment which we are probably going to recommend at that time. Now, the risk factors for ischemic stroke. We have got modifiable risk factors, right? Hypertension is foremost now. Besides aging, of course, age is also very important. The older you are, higher the risk you have. But those are not risk modifiable factors, right? The age. It has been seen that once you have come to age 55, the incidence of stroke actually doubles for every 1 decade in age after that. So hypertension is a modifiable risk factor. Physical inactivity comes in next. And dyslipidemia, right, that's also taken into consideration because all these are treated to target actually. And of course, unhealthy diet has been a contributing factor. Obesity, right, abdominal obesity, where we take into consideration waist to hip ratio, that's more sensitive than your BMI actually. Current smoking, atrial fibrillation, for which charge to DS2 score and HBS score has been actually considered in the management of this condition. And diabetes mellitus, just like in infarcts, you've got a higher risk, right, of getting a stroke. And alcohol consumption. Well, there's also an ethnic preponderance in strokes, right? In our region, we have got higher incidence actually found in the Malay population, right? It has been seen that demographically, 85% of them are Malays, and about 9% are Chinese, Indian 3%, others are 3%, right? And as far as genetics is concerned, they normally have a inherited monogenetic cause, right? Now, how quickly should a stroke TI be investigated? If you want good results, they have to be immediately investigated. Therefore, it's an urgent treatment. TIA is not to be taken as something light, as one-time talk, as was one time considered. It can be as high as 10%, right, or ending up in a stroke. Therefore, you need to approach it aggressively. You will ask for a non-contrast CT and consider secondary stroke prevention after that. And the time-proven drugs like antiplatelet agents and statins, these are also part of the drugs which we use in stroke management. All right. Blood pressure control, ideally below 140/90, 130/80. If you have an underlying medical condition, they reduce the risk of stroke by about 70 to 80%. Right? And although the drug which is actually of greatest benefit is still aspirin, right? But even then, after optimizing everything, there's still a risk of 2 to 3% in a week after getting a stroke. Now, how do we estimate the risk of TIA? Right? We have got a score which has got independent factors, right? ABCD2 score, right? Where age over 60 carries 1, blood pressure above 140, systolic above 90, diastolic carries 1 score, right? And then you have got features of TIA. Is there I think most of us are aware that even in our news, in our radios, the public has been educated on this. Be fast, right? Come to the emergency department early, because the main idea is to be assessed early and consider thrombolysis if they qualify for it. Now, you have got unilateral weakness with or without speech impairment that carries 2 score, or just a speech impairment without weakness carries 1 score. Now, the duration is important. More than 1 minute, more than one hour, that is more than 60 minutes, it is 2. And it's between 10 to 59, it is 1. If it's less than 10, it doesn't carry any score. And the maximum score you can reach is actually 7. Researchers have shown that the 2-day stroke risk for scores of 0 to 1 is about 1%. And the score increases, the risk is higher. 4 to 5, it's about 4.1%. And when it is maximum 6 to 7, it's almost 8. That is the 2-day risk score. You can extrapolate this to a 90-day score, and still there's an increased risk if you do not attend to them appropriately. Now, what are the workup which you like to do? Standard workup, which most emergency department has these days, right? Neuroimaging. All right, so CT scan, that's what should be done because it can be done early. It helps to identify hemorrhagic stroke from ischemic stroke. And subsequently, once the person has been stabilized, you will look for other risk factors, diabetes, lipid profile, which should be done early. Echo the heart, right? If you think it's an embolic stroke, Holters, vessel imaging, all this has to be done. All right, and according to the history, you will screen them according for the specific causes, antiphospholipid screening, thrombophilia screening, etc., as and when it's needed. Now, as far as the management is concerned, antiplatelets are in the foremost, right? Even in the STORE study, this has been tried actually. And if you think it's a cardioembolic stroke, we have got anticoagulant, right? And the drugs which we are all familiarized with is actually aspirin and clopidogrel. That's what is being used very aggressively, right? And we are familiarized with these drugs. Now, anticoagulant warfarin has been replaced by and large by the new oral anticoagulant or the novel oral anticoagulant drugs, right? The newer one. Or some will call it as the direct oral anticoagulant drug, which is actually the preferred term these days. Now, these drugs are cheap and effective. Gliprin, glycinated aspirin, only costs 9 cents per tablet. Or Winsprin, which is soluble aspirin, 22 cents per tablet. Clopidogrel, 30 cents per tablet. Now, I think the slides have run a bit, they're not like what I gave anyway. Well, aspirin, well, all of us are familiarized with, and the dosage ranges from 75 to 325 milligrams daily. This has been proven by many trials, and it has appeared in Lancet in 1997, and also in the CAST trial, Chinese acute stroke trial, again in Lancet. So it is one of the main drugs which is used in strokes actually, right? Okay. Now, clopidogrel came in much later after that. And a lot of trials have been done comparing aspirin with clopidogrel. The absolute risk reduction is higher, right? Is with clopidogrel compared to aspirin. A combination of both of them can be harmful if they are used for a long time. All right, a combination of this. Well, this again has been proven by several trials. The Capri trial, right, which is actually clopidogrel, the Capri trial, right, which is used compared with aspirin in ischemic stroke, and another trial called Match trial, right, where again it has been proven that anticoagulants, again, these two drugs can be used and they are found to be beneficial. Came out in the Lancet actually. Now, these drugs, silestazole, they are all alternatives if you do not have people who can't take aspirin or clopi. Right? Now, let's go by a case study. Right, we have got a 61-year-old gentleman who's right-handed. He presented to the emergency department. Actually, the slide has totally been, I don't know, somehow it has changed its form already. Sudden onset of left face, arm, and leg lasted for 40 minutes. The onset was 8 hours. You can notice here that you are going to go for the weakness, right? What are we going to do to this person who has come in with right-sided weakness? Onset was 8 hours ago, lasted only 40 minutes. So here we have to consider the ABCD2 score, which I mentioned earlier. The BP is high, 145/90. He has got type 2 diabetes. He is hypertensive. Now he's got gastric ulcers. All right, so that also has to be considered, past history of it. And these are the drugs he's been on. I've done a scan, a CT scan, plain contrast CT. You can see there near the thalamus there's a hypodense area. And in TIA, many clinical trials have been done, and this is the 90-day stroke risk score after TIA, right? In many express trials have been found. You notice that the initial part, the first few days itself, there's a risk of stroke, significant to as much as 6%. And over 90 days, the risk can actually go up to about 10%. Now, in this gentleman, we are going to estimate the ABCD2 score, and you notice that he has a score of 6 and he falls into the category of high, right? For a 2-day risk for stroke, high. And a recurrence rate 2, right? He's going to go get a stroke and maybe a recurrence of 8.1% over 90 days, right? This is from the JAMA journal, actually. Right? Now, the dual antiplatelet therapy for minor strokes, right, has now been in practice already for a couple of years now. For minor strokes, we have got a scoring system of NIS below 3, right? So, National Institute of Health stroke scale of 3 and below, or a high-risk TIA score of more than 4. Now, this double antiplatelets has been recommended for a limit of 21 days. Right. Now, this trial here, chance trial, all right, which is actually clopidogrel, right? Clopidogrel in high-risk patient with acute non-disabling cerebrovascular event. And they have got another point there, which another trial which was called a point trial, which is actually platelet-orientated inhibition, right, in new TIAs. Both these trials, one came out in the New English journal, in New England Journal in 2013. The other one came out in 2018. Both of this trial actually favor intervention, right, with double antiplatelet, both of them, for first 21 days. Although the risk of major hemorrhage in the point was slightly high in comparison to the chance trial, where the risk was actually similar with both groups, whether they used it alone as aspirin or clopidogrel. So this is a point to take. For 21 days, we go on with a double antiplatelet therapy. Subsequently, we just go on with one. And most of the time, we are going to use aspirin. So there's going to be a loading dose, followed by a dose of 75 milligram in the emergency department of clopidogrel. Aspirin is 75 milligram for the first 21 days. And then they continue 75 degrees for 90 days, or 3 months. Most of the studies have been made for 3 months to see the stroke outcome, actually, whether they deteriorated or whether they improved or whether they prevented a recurrent stroke. Right. Now, on the second day of admission, unfortunately, he had a partial anterior circulation stroke, right? The same patient, he had left-sided weakness, left homonymous heminopia, all right, and dysphagia. The GCS was full, and the NIS score was moderate, 10. Second day already, he developed this, right, of admission. And they done a non-contrast CT, and they found a dense MCA sign, right, also known as GAG sign. You can see a hyperdense area there, all right? And sometimes this is the only finding you can get in an ischemic stroke, where you can have increased attenuation of the proximal middle cerebral artery. That's often associated with thrombosis of the first branch of the middle cerebral artery segment. That might be the only early features, right? ECG was done. It was in sinus rhythm, but it still cannot prove paroxysmal atrial fib. Echo was done in the emergency department. Of course, Holters was not done. Now, the final diagnosis, provincial diagnosis, was right partial anterior circulation infarct. All right. And going by the classification, right, in the STOS studies, we have to consider even cardioembolism. Right? In the STOS studies, they have categorized, they classified such stroke as large artery atherosclerosis, cardioembolism, small vessel occlusion or vasculitis, and of course, you have got stroke of other determined, right, etiology and undetermined etiology. So these are some of the things which you have to consider in the management of this patient. Now, there are some features which you find in people with AF as far as cardioembolic stroke is concerned and atrial stroke. There are some features, right? Because if you do not manage them appropriately, you can get a stroke recurrence in atrial fib, right? Especially with those people who have got concomitant carotid artery stenosis, right? The recurrence rate is actually doubles in such kind of case. Now, we have to consider whether atrial fib is always a culprit of stroke in patient, all right, with atrial fibrillation, or is it because of a concomitant, all right, carotid artery stenosis, which the person may have. Now, the atrial thrombotic stroke is more common in males compared to cardioembolic stroke, which is more common in females. And there are some distinguishing points between these two, cardioembolic stroke and atrial thrombotic stroke. And in the atrial thrombotic stroke, we've got incident prevalence of diabetes, smoking, peripheral artery disease, dyslipidemia, and so forth. And the TIA seem to appear in the same vascular territory as opposed to those with people who have got cardioembolic stroke. They appear to appear in different vascular territory. And you have significant artery stenosis in atrial thrombotic stroke. Whereas in those with cardioembolic stroke, they tend to have a left atrial enlargement or dyskinetic myocardial segment. All right, and imaging will show embolic infarcts involving the cortex in cardioembolic stroke. And atrial thrombotic stroke, we have cortical, subcortical, borderline infarcts within the same arterial system. And now the use of aspirin or with anticoagulant, your fear is whether they have got hemorrhagic transformation, right? Which is not rare in those people who got cardioembolic stroke, right? But those with atrial thrombotic stroke, this incidence of hemorrhage is less. So actually we have got a very complex case to consider when a person has got this etiology as a cause of stroke. Now, there was a trial called the SUMPRIS trial, right? The SUMPRIS trial, it means, does stenting help? SUMPRIS simply means stenting versus aggressive medical management for intracranial arterial stenosis, right? They found that the primary endpoint of recurrent stroke or death was actually much lower than expected, right? In those with medical management than using a stent, which is actually still investigational, right? Much lower, 5.8% within 30 days, 12.12% within 1 year, compared to controls, 20% at 1 year, right? Now, recent stroke or TIA within 13 days for those with severe stenosis of a major intracranial artery, clopidogrel is reasonable for this kind of people, right? So you can add clopidogrel, 75 milligrams aspirin for 90 days. You should maintain a BP to acceptable level, treat to target below 140. You use high intensity statin therapy, right? We have to optimize the medical therapy. Now, angioplasty and stent, the outcome is still in the investigational stage. There's no role for bypass, axial carotid bypass in those people with intracranial atherosclerosis. So this SUMPRESS trial strongly advocates medical arm as the choice of treatment. Now, what do I do with such kind of person? Those with acute ischemic stroke and TIA. If they come within 48 hours, they have not had opportunity for going in for thrombolysis, right, or for thrombectomy, we can load them with aspirin 300 milligram. If they have undergone thrombolysis or thrombectomy, we can restart aspirin again with 150 milligram. Now, those with a high-risk TIA score of more than 3 or a NIS score of below 4, you can add a combination therapy. Aspirin 150 once daily, clopidogrel 75 milligram for 21 days, and then go on with aspirin. For small vessel disease, we may just use a loading dose or higher dose of aspirin of 300 milligram for 2 weeks, then 150 milligram once daily. And those with large vessel disease, we can continue a combination of aspirin, clopidogrel for 90 days followed by aspirin. Now we have another case. These are all real cases, all right, which came to the emergency department. Now we have got a right-handed person with who's hypertensive. BP is 170/90, and was last seen well 10 p.m. Very often we get this wake-up stroke. When they get up in the morning, you find they got a stroke. He presented to the emergency department at 8 a.m. and noted to have a right-sided hemiplegia with the eye deviated to the left. He was aphasic, and there was reduced blinking to visual threat on the left. Now, the diagnosis was actually a total anterior circulation stroke on the left side. Well, some of the features are hemiparesis, higher cortical dysfunction, he was aphasic, right? And he has visual spatial neglect, right? So the puncture diagnosis left, total anterior circulation syndrome, right? They did a NIS score, it was 16, ECG was done. He seems to have atrial fib, and he had a CHA2DS2-VAS score of 3. Of course, we also did a Hasbled score, right? And then we have to decide on the management, right? He was hypertensive, and his age was between 65 and 74, right? And sex category, female carries 1, right? So this is what we saw just now, a dense stroke, a total anterior circulation stroke, which we saw just now, involving mainly the middle cerebral artery, hypodensuria. What's going to happen to this person? There's going to be a recurrent risk of a recurrent stroke, 3 to 5% within the first 2 weeks, and 12% per year, right? Now, we are very much concerned with this because we know that we have to consider DALI, disability, adjusted life years. In Malaysia, in fact, it has been seen that in 2019, there were close to about 48,000 incidents of cases of stroke, close to about 20,000 deaths, right, in 2019. And the prevalent cases of stroke was actually about 450,000. And the DALI, right, disability adjusted life years, was actually around more than 500,000, 515,000 or something like that, around there, more than 500,000. Now this is important because, right, it actually expresses the disability of ill health, disability, and even early death. Now this DALI was actually developed somewhere about 30 years back. It just compares the overall life and health expectancy of different countries, right? So we really have a lot to go forward to improve our stroke management. Now, which antithrombotic would you use? Is there a role for parenteral anticoagulant, aspirin and oral anticoagulant, warfarin, or the newer oral anticoagulation drug, dabigatran, etc.? We have to always consider higher stroke and bleeding on vitamin K antagonists. Warfarin has been there for a long time. In fact, it was even during my student days, notes were, when we had our exams, short notes were asked on warfarin, right? The higher risk of stroke and bleeding with vitamin K antagonists, this has been particularly seen, right? You see here that Asians are at a higher risk. The Japanese are the lowest risk. And the non-Asians comes next. Now this ROCKET trial for atrial fib, Aristotle's trial, all these trials were actually done for atrial fib. They were comparing, right, the newer oral anticoagulant drug. Actually, I've got no conflict of interest to declare, right? I'm not promoting the NOAC, actually, right? And they always compared both. And in fact, I still remember how aggressive the sales representatives were. You know what they were telling us? Why are you still using warfarin, the rat poison? We know that warfarin is actually one of the components for rat poison. But again, we are very comfortable with warfarin because we have used that for time over and again, right? But then over time, those people who can afford, many of them, and there was no contraindication, they switched on to the newer drugs. The ROCKET trial was actually rivaroxaban, right? Which was used once daily, oral route. It's a factor 10A inhibitor, actually. And nowadays we have got antidotes for these drugs too. So it's very safe to use, right? Compared to vitamin K antagonists, we have got warfarin. Also, we have got antidote for that too, right? But again, it's more cumbersome to use. You have to maintain an INR. That's another issue here. With Asians, INR, right, in the time to treatment range is actually not less than 70% for it to be of any use, right? So in the ROCKET trial, which is rivaroxaban once daily, oral anticoagulant, right, compared to vitamin K in the prevention of stroke, and also for systemic embolism. Rivaroxaban versus warfarin, it was found that rivaroxaban was superior, actually, right? Now, in the Aristotle trial, there was another NOAC use, epizaban, all right? And that is used for reduction, Aristotle, reduction in stroke and other thromboembolic event in atrial fibrillation trial. Epizaban versus warfarin. Again, it was seen that Asians as such, right, had major bleeds in comparison with others, right? So the RELY trial actually was another trial where they randomized, right, evaluation of long-term anticoagulant therapy. They were using dabigatran, actually, right? They were using dabigatran. Here again, it proved that major bleeding was a problem. So the cases which I mentioned earlier, you have to consider all these drugs, whether to be used on warfarin or are you going to use the NOAC. Now the ROCKET trial, again, you can see there that they actually compared it with the numbers there, 2 to 3 is actually warfarin, the INR range, right? The INR range. In ROCKET trial was 2 to 3, Aristotle was 2 to 3, RELY trial same, and so forth, if you're going to use that. Now, Asians had higher intracranial bleed risk on vitamin K antagonists. And you can see here, right, from here, the events-free probability and the adjusted intracranial hemorrhage event-free curve, which is much higher in Asians, right? They have got a 4-time increased risk of intracerebral bleed, right? And this was recognized much earlier, actually, even 20, 30 years back. They had a high chance of intracranial bleed. Now, Asians have low time to therapeutic range, right? You can see here, Asians, a significant number of them do not reach 2, less than that, right? You can see that. And you can see the subtherapeutic INR. And these are all elderly patients, 65 and above, right? Most of them. A significant number of them have not reached the therapeutic range. That's below 2, the one which is colored orange, actually. When you compare it with the other regions, right? Where a significant number of them, right, are in the therapeutic range. Or the green portion is what we are aiming for, which is found in others. So they are not very user-friendly for Asians, I would say, right? There are a lot of reasons for that. Now, you compare the direct oral anticoagulant or NOAC with warfarin in the secondary prevention, all right? A lot of trials have been done, and they have found that the stroke and systemic embolization was reduced with the newer agents when compared to warfarin, right? Warfarin compared to that. You can see here also studies on Aristotle. All this was actually studied. Aristotle, Rely was using dabigatran 110 milligram and 150 milligrams for younger patients. And again, the Rocket trial, Rivorazaban, right? So now we do not have to fear this because there are antidotes for all these drugs nowadays. We have got antidotes for all this. We are using for vitamin K, of course, we have to use prothrombin complex, right? Concentrate, sometimes factor 7A. These are the drugs, fresh frozen plasma, right? But we have got drugs for dabigatran, for instance. We have got idarucizumab as a very specific reversal agent. And you've got universal reversal agents like antigen, which is already available. I think in the private hospitals available in this country, right? So if you want to revert them back, it's easy. Suppose somebody has any medical emergency going in for a surgery, it's very easy to revert them back. Antigen is a universal antidote, which can be used for epizaban and the newer drugs. Right? Hemorrhagic stroke. That's a real concern to us too, right? Somebody has already got an ischemic stroke and used this and ends up the hemorrhagic stroke. The risk reduction actually has been reduced by the odds ratio, in fact, and it's actually below 56% in those people. So it's quite relatively safe compared to your vitamin K antagonist. Now, bleeding risk is much lower when you use this type of drug. In the Aristotle trial, it was proven. Now, the number needed to avoid one major bleed was actually 65 with those without stroke, and previous stroke was even lower, 54, right? So the bleeding was again better and less risk when you're using this agent. Now, this is our fear. An ischemic stroke can end up with a hemorrhagic transformation. And I think I've already given you some evidences of the drug which is to be chosen, preferably compared to vitamin K antagonists. Now, can it end up? Now, we're going to use this drug because our concern now is recurrent ischemic stroke. Or are we going to end up with a hemorrhagic transformation if you start them too early, right? Now, the timing. What's the best day to start this with somebody with an embolic stroke, which had ended up with ischemia? Is it day 1, 3, 6, 12, or 30? Right? Many guidelines have come up to support the initiation of anticoagulation therapy for secondary prevention of ischemic stroke. Right. Going by the European Society of Cardiology, Anybody with TIA, you should start off with day 1, right? And if you have got a minor stroke where the NIST score is below 8, you can start off with day 3. For mild stroke, between 8 to 15, day 6. And for severe stroke, day 12. I think this is what we are following in most of our hospitals in Malaysia, 1, 3, 6, 12. Now, the European Stroke Organization in 2019, according to the infarct size, whether it's mild or small, they will start in day 4. Moderate to medium, day 7, and very large, day 14. Americans, again, they have got their own guidelines, anywhere between 4 to 14 days. Now, for the Australian, TIA is urgent. Start in day 1 itself, right? And moderate stroke, anywhere between 5 to 7 days. Severe stroke, 10 to 14 days. Now, the consensus statement in Middle East and Northern America, right, is anywhere between 12 days, and if it's a large stroke, 2 to 3. So you can see here itself, more or less, many of these guidelines, more or less, are close to the recommendations, right? Anywhere between 1 for TIA, day 1, and then for mild stroke or even severe stroke, 3, 6, and 12. This is what we are practicing here. All right, this is what we are practicing in most of the hospitals in Malaysia. Of course, you got to do a CT scan first before you start them again, right? Now, anybody TIA or stroke, this is just a summary of what was told. We have to exclude any intracranial bleeding by CT or MRI. Make sure it's an ischemic stroke. If it's TIA, after day 1. Mild stroke, after day 3. Moderate, after excluding hemorrhagic transformation, you got to do a CT and MRI at day 6. You can start at 6 weeks. So therefore, we got to do another CT scan for them. And for severe stroke, when it scores more than 16, you got to exclude hemorrhagic transformation at day 12 and start after day 12. So some of the clinical factors which will favor early commencement, initiation of oral anticoagulant, or you want to delay it. They will go by the NIST score. Below 8, you can start early. Above that, 8, delay. On imaging, you find there's no brain infarct or small, you can start early, right? There's a high risk. If you do an echo of the heart, you found a cardiac thrombus, you better start early, right? And then, is there a need for surgery? There's no need for carotid surgery. Start early, right? Somebody who's clinically stable, young, better start early. All right, and the BP is controlled. You can start them early. Now, all cases which come in, you got to consider them for thrombolysis and mechanical thrombectomy. Now, if the person is eligible, you have to start thrombolysis. And you will withhold the anticoagulant and antiplatelet at least for 24 hours. Right. If it's not eligible for thrombolysis, you will start aspirin as soon as possible within 48 hours while you're trying to determine the cause of the stroke. As soon as possible, preferably within 24 to 48 hours. And of course, cardiac embolic stroke due to AF, you would like to start oral anticoagulant depending on the characteristic which I mentioned, 1, 3, 6, and 5. No, you got to follow this route. This is from the American guideline 2015 and the European guideline of stroke in 2016. All right, so this is summary of all this, of what we have said just now. patient with TIA or ischemic stroke, lifestyle modification, education, and you got to treat to target weight loss, encourage physical activity, stop smoking, reduce alcohol intake. All right, lifestyle modification, hypertension, treat to target. High risk, you want to bring it down lower, 120 to 130 over 80, their blood pressure. And of course, your lipid, your LDL-C should be again treated to target. Use statin, right? You're going to use the high intensity statins. And anti-diabetics, treat to target weight loss, etc. Now, besides that, antiplatelet therapy, your short-term 10 to 21 days aspirin plus clopidogrel, and then after that you can decide on aspirin or clopidogrel, or aspirin, or you can even use extended release dipyridamole, percentin, right? Which also is available in our government hospitals. Percentin, yes, it's available. Those with cardiac embolization, you can use either warfarin, although your direct oral anticoagulant is preferred. Sometimes we have got people where we can't take for some reasons or so. Those people are contraindicated. We can use a left atrial appendage occlusion. We have got this I've seen this device from IGN. Watchman device, for example, we have seen this. It's being used. Now, if you do not know the cause, you can start on aspirin. Those which have got patent foramen ovale, you must encourage closure. All right? If they are below 60 years. Symptomatic carotid artery stenosis, 70 to 99%, and endarterectomy or stenting is recommended. And of course, when it comes to intracranial stenosis and vertebral stenosis, there's some pre-trial again. Best medical treatment is advocated, right? Stenting are still under investigational. Right, so these are the readings and the resources which are used and even updates. Right, thank you very much. Right.
Thank you, Prof, for wonderful updates on the recent stroke prevention strategies. So I would like to invite all the audience. If you have any questions, please post your question in the comment box. So here are some of the comments, Prof.
Yeah. Still in holiday mood. I'm holidaying here in Penang. I'm actually speaking from one of my relatives' place in Penang.
Thank you, Prof.
Yeah.
Prof, there is a question.
Yeah.
Which stroke has poorer prognosis, thrombotic or hemorrhagic stroke?
Right. Hemorrhagic stroke, the immediate event has got a worse prognosis than thrombotic stroke. But long-term prognosis is worse in thrombotic stroke. Immediate, yes, hemorrhagic has got a worse stroke. Worse prognosis, hemorrhagic stroke. Yeah, compared to thrombotic, immediate event, right? But the long-term, suppose they recover from hemorrhagic stroke, then your thrombotic stroke are the one which sometimes tend to recur. They've got worse prognosis in the long run, in years to come.
Any further questions? Yeah.
Streptokinase is not used at all. All right, they always used drugs like alteplase, and some cases of the other drug, metylase, tenecteplase, as a second line has been used. All the studies have been done with alteplase actually. That's what we have in our emergency department. Maximum we can give is 90 milligram 10 milligram is given in the first minute, and the remaining is finished over 1 hour. Remaining, that means over another 50 minutes. Right? We finish it off. 59 minutes. That's 1 hour for all. Yeah. LT places was being used. Streptokinase, there's no role at all.
Any further questions from anyone? So please fill the form for your e-certificate as well as the CPD points.
Thank you.
One more question, Prof,
Yeah.
from the same.
Well, he's on aspirin, of course. It's not an absolute contraindication. Because aspirin takes time to be worn off, right? It takes time to be. So, of course, we are going to refer them to the neurosurgeon, and then they will decide on what is best for him. Right? But aspirin is usually not a problem. It's clopidogrel, which we fear most. Usually, aspirin is not a problem. Warfarin is another thing. Warfarin, we can revert back very easily. We can use prothrombin complex. Now we have got very specific factors even for factor 2, 7, 9, 10. The vitamin K antagonistic factors 2, 7, 9, 10. We can ask for, I'm talking about warfarin. Huh? Because aspirin, I hardly see anybody having a bleed because of aspirin, right? Causing emergency stroke. Yes, warfarin, we have seen many, even within the normal therapeutic range, we have seen many. And we always revert them back by using prothrombin complex concentrate. And nowadays, we have got very specific factors. We have got factor 2, 7, 9, and 10 being given. All right. In this, I just saw it the other day. Even in HKL, they are using it when we had a case of a stroke there. So we can revert it back. And now with the newer drugs, which I already mentioned just now, we have got very specific antidote. But aspirin, of course, I've hardly seen anybody with a bleed because of aspirin. I think we should consider, is it an embolic stroke which he has got, all right? And it has undergone malignant transformation. All right, so usually they will go by clinical features. The surgeon has to decide on that. We can't revert back there. It takes about a week for aspirin effect to wear off, actually. Hardly seen. It's mostly warfarin, yes. Clopi, yes. Many studies have shown clopi can be a problem, especially when they're used in combination aspirin. That is why after 90 days in some strokes, they'll continue with a single one of this. But even then, the CHANCE trial supported the use of both, right, with good results.
Thank you, Prof.
Right.
So if we don't have any further questions, thank you so much, Professor, for your wonderful sharing session on the current strategies in the secondary stroke prevention, which is the most common mortality in the country. So which is very useful for everyone. Thank you so much once again.
Thank you.
Thank you all participants for your interest in participating in our
Thank you
webinar.
very much.
Thank you so much.
Have a nice day. Thank you. Bye.
Okay, stop.